Good afternoon. My name's Nadeem Shaida. I'm an interventional radiologist based at Addenbrooke's Hospital in Cambridge, and it's a great pleasure for me to be able to speak to you today about AblaSure, which is the quantitative margin assessment tool available from CAS-Nation. These are my disclosures. So I'm mainly going to talk about HCC today, although what I say is equally applicable. In fact, it may even be more applicable to other types of liver tumor. But the issue with HCC, as we know, is that it's a slightly unusual tumor in the sense that the diagnosis is usually reached on the basis of imaging. And we only reserve biopsy for situations where the imaging is non-diagnostic. And straight away, this brings up an issue, because what we know from pathological studies and what we've known for a long time is that what we see on imaging may not represent the entirety of the tumor. As this study from 2005 showed, many patients, particularly those with larger tumors, have small satellite nodules around the edges, and these may or may not be visible on conventional imaging techniques. And so we come to this point where we need to have a solution to evaluate our treatment success. And this comes from a paper which I'm going to mention in a little while. And so we come to what's the consequence of incomplete ablation? Well, what's been known for quite a long time, both for HCC and for other types of tumor, is that if you get incomplete ablation, you're more likely to get local recurrence or recurrence at the treated site, and this does actually have an effect on prognosis and overall survival. And there's quite a lot of data to indicate this, both in the HCC population and also in the liver metastasis population. So we come to the fundamental problem. We know that sufficient margins are the most important aspect in reducing tumor recurrence, but how can you be sure that you've managed to get a sufficient margin? In other words, how can you be sure that you've managed to get what's referred to as an A0 ablation? Well, it requires a sufficient safety margin. I'll mention a bit about that in a minute, but this needs to be at least 5 millimeters. And traditionally what we've done is use conventional imaging methods of assessment. Obviously, if you're doing ultrasound, all you see is a snowstorm, and it's virtually impossible to assess even whether you've covered the tumor, let alone sufficient margin. But with CT, what you tend to do is you look at the pre-picture and the post-picture and evaluate them and work out by eyeballing them, have you achieved an adequate coverage? What are the challenges with this approach? Well, the obvious challenge is that it seems to be subjective and prone to reader variability. And this was very elegantly shown in this paper, which looked at, well, it's actually about 9 patients with their pre and post CT scans, but the scans were shown to 38 interventional oncologists based in 14 different countries. And what they found was that there was a huge variability in how the scans were interpreted. And ultimately, there were 37% of the scans that were overcalled as being adequately treated, and 46% that were undercalled. And the very interesting thing about this paper was that amongst the cohort of readers, just under half of them were what would be considered as expert interventional oncologists, based on the fact that they'd got experience themselves of more than 50 cases. And yet when you looked at their ability to evaluate these studies, there was absolutely no difference between their outcomes and the non-expert group, which I found absolutely fascinating. This is another paper looking at microwave ablation in 58 patients with 3 readers, and again it shows the same sort of thing, large variation in ability to evaluate CT scans. And then we come to this paper, which is a superb paper, which looked at 176 HCCs and 110 patients who had scans pre and post ablation. And these scans were then fused together, and essentially a minimal ablative margin was measured for each of these patients, and then they were followed up. And there were 2 or 3 main points that came from this paper. The first thing that came that's absolutely critical to understand is that minimal ablative margin was the only predictor, the only statistically significant predictor of local tumor progression. So that's absolutely key to understand, not the patient factors, the ablation factors. Second thing was that a minimal ablative margin of 5 millimeters or greater than 5 millimeters correlated with a completely treated tumor, with very few cases going on to have any sign of local recurrence. And the third point that was made, which is the quote on the earlier slide, was about the fact that this was done using a kind of slightly complicated reconstruction and fusion technology, hence the comment about trying to find an easier semi-automated method of evaluation. So this is how it works. As previously, you start off by selecting and identifying your tumor. What you do next after that is you can either use automatic segmentation for it to identify the tumor, or you can manually correct for it yourself. And what you see is you have the red circle, which is the tumor itself, and then you have a yellow circle around it, which is the tumor margin or your safety margin. And you're able to adjust the margin to a distance of your choice. In this case, you can have 5 millimeters or 6 or 7 or whatever you wish. Having done that, you then go to the tool and select the probe that you're planning on using for this case. And all of the major manufacturers are included as part of the CAS-Nation software. You then set up your ablation parameters in terms of power and wattage and duration if you're using microwave. And what the software will do is it will show you by means of a green circle what the ablation margin or the expected ablation will be with that probe at that setting. The next step then is to place the needle where your intended target was. And once you've done that, what you want to do is you want to verify that your needle tip or your needle is in the correct place. And the software will, as we've seen, enable you to do that by fusing a unenhanced needle tip position scan with your original scan. And what you can see is that it will show you where your green ablation zone is going to be if your needle tip was in the current position. And as in this case, what you can see here is that the needle tip has ended up fractionally further in than was originally planned. And you can see that on the right-hand side of the screen, where it tells you the depth is that it's in about 3 millimeters too far. So what you can now do is you can, obviously you're going to want to pull the needle back, but before you do so, you can model what the green ablation zone is going to look like if you do so by changing the depth button on the right side of the screen by 3 millimeters. And that shows you here that the green ablation zone is moving backwards, and now you've got adequate coverage of both the tumor and the safety margin together. The next step then is to perform the ablation, and then once that's done, the idea is to validate using the AblaSure technology. And the way this works is that after you've done your ablation, you then do a second post-contrast CT scan of the liver. And what the software will do is it will automatically segment out the ablation zone and then fuse it with the original CT scan, which showed you where the tumor was. By doing so, it is able to overlay these and then measure the distances between the tumor and the safety margin to the actual ablation zone. And it will represent that pictorially in the way of a histogram, which we can see in the top right corner there. So just to explain that in a bit more detail, the red circle represents the tumor. The yellow circle represents the safety margin, and the green circle represents what has ended up being ablated as determined by the segmentation software. And what the software will do is that it will look at numerous points around the edge of the tumor, and it will measure the distance between those and the ablation margin. So if you look at a distance like this, which is D0, clearly what we can see is that what has been ablated has not covered the tumor. So if you look at the histogram on the right of the screen, what you'll see is a percentage visualization of how much of the case that has happened in, which shows you that anything to the left of the 0 margin, negative margin, essentially means the tumor has not been covered. The second situation is the one we've labeled D2 here. And what we have is the ablated volume has covered the tumor, but it has not yet covered the safety margin. And that's in that gap in the middle between 0 and whatever you set your safety margin to. So you can see quite a lot of blocks in the histogram in that area. And that's really the group we're interested in, because that's a group of patients where previously we might have thought we've done enough, but we probably haven't in retrospect. And then finally, you have the third situation, which is D3. And this is the group where the ablated volume covers both the tumor and the safety margin. And that's represented there on the histogram to the right of the yellow line. So here's an example of that. This is the case from earlier. This is the post-ablation CT. It shows you where the ablation zone is, but you need it to be auto-segmented. So the way that the auto-segmentation works is that it requires you to define what's called a seed point, which is an area within the ablation zone that you pick, which is relatively homogeneous, and it will then automatically detect the ablation zone based on Hounsfield unit attenuation values around that. You're able to adjust it to a certain degree manually, but much of it is done in an automated fashion. And then once you've done that, it automatically then generates you the histogram. And as you can see in this particular example, we can see that there is nothing to the left of the 0. So the ablation zone has covered the entirety of the tumor. But you can see there's quite a bit in the zone between 0 and 10 millimeters. So in this case, the margin was set at 1 centimeter, which is quite a generous margin, and much of the ablation is into that territory. So based on that, you might decide to do something else, or you might decide that that's sort of enough. And you can see the bit towards the end of the screen on the right-hand side of the yellow line is the part of the tumor where you've covered both the tumor and the 1 centimeter ablation margin. And of course, what the software will enable you to do is to look through the images in 3D and work out where, if anywhere, you've missed the tumor or missed your margin, so you know where to go to try and reposition your needle. So this is a patient from my institution. He's a 60-year-old male with cirrhosis and portal hypertension, being considered potentially for a liver transplant. He has a large hemangioma in the left lobe, and he's got a 39 millimeter lesion in segment 6 of the liver, which is just visible on the arterial phase. And this previously was treated with 2 attempts at transarterial embolization, and effectively that made absolutely no difference whatsoever. I think there was a reduction from 41 millimeters to 39 millimeters. Now, the reason the patient previously had undergone an arterial embolization procedure rather than ablation was that the feeling in RMDT at the time was that this was of a size that was bigger than 3 centimeters, and therefore we should not be treating this with ablation, and the patient should have embolization instead, despite the fact that we all know that embolization has a far poorer outcome than ablative technologies in HCC. But with the advent of this type of software and the CAS-nation machine in general, it was apparent that we could try and treat larger lesions by using multiple needles. And so that's what we try to do in this case. You can see the tumor there with its margin on the left side of the screen, and then you can see our ablation probes. And this takes a little bit of positioning of the needles to try and get your green circles to kind of overlap the red circle, the red tumor, and as much of the yellow circle as is possible. And so here's the unenhanced CT showing the positioning of the 3 needles, which was very straightforward with the CAS-Nation software and machine. And this is what it looked like when we put the needles in, but we hadn't done the ablation. This was the planned trajectory. And you can see that in some areas, we're not quite covering as much as we'd like to cover. And so this required then a bit of repositioning of at least 2 of the needles in this particular case. So after repositioning and after doing the ablation and employing the AblaSure technology, we ended up seeing this type of histogram. And what you can see is when you look at the multiplanar reformats, you can see we've got good coverage of the majority of the tumor and the safety margin, apart from right at its very cranial aspect, where you can see we're very, very close. And that will be in this area between 0 and 5 millimeters. And so, interestingly, when you look at the CT post-procedure on table, you can see just about that the upper limit of the ablation margin is immediately adjacent to a large portal vein branch, which so there may be an element of heat sink accounting for this. So I guess the decision to be made at that time is whether or not you then go on, and you probably should to re-ablate the top end. So this patient has had 2-month follow-up scan, which so far looks very good. We can see the ablation cavity there. We're not seeing any evidence of local recurrence at this very early stage, although naturally I was watching the top end very carefully to check that there was no obvious recurrence at that cranial-most margin. Overall, this case kind of highlights 2 or 3 things that I think are quite relevant and quite interesting. The first thing is that the case selection in particular at the beginning in our institution, as I say, we were very much following old traditional guidelines about not trying to treat tumours with ablation that were more than 3 centimetres, but it's very easy to do. You can do that with technology like this. And the second thing about it, which was when we're doing the procedure, and when we've done a few of these AblaSure procedures now, is that I found that the role of the interventional oncologist or the operator is slightly different now, because when you get to this stage of validation, there's a whole extra bit of thinking involved. It changes your intraoperative decision making, and it even slightly changes your role, because you've got to sit there and look at it really carefully in 3D and work out what the margins are. But the semi-automation of the software of the AblaSure technology makes that very, very easy to do. And the third thing that I thought that struck me about this case was, as I said, we were a bit worried about the top end. It may end up being that you end up doing cases that change your follow-up imaging strategy, that you might change the time interval between doing follow-up scans if you're particularly worried about a particular area. So to summarize, I hope we've shown that incomplete ablation is the kind of Achilles heel of thermal ablation. But quantitative margin assessment using technology like AblaSure provides a solution to this, and it does this in a number of ways. The first thing it does is it democratizes the process. What do I mean by that? Well, what I mean is that you don't have to be in a specialist center with super specialist equipment that only a few people around the world have access to. Technology like this will open the doors for many centers to be able to do more and more complex ablations and do less complex ablations better than they were previously doing them. It does this by quantifying the technical success. So you can say with absolute certainty, I've got this margin. Then remember, the surgeon has the pathologist to tell him when he does a resection that all of the tumor is gone. We have no similar ability other than technology like this, but this is a huge step towards achieving that. The next thing it does, it standardizes the process and it increases reproducibility. And of course, it increases transparency about what has happened during the procedure. And I have to say, I would love to see these treatment plans in the future forming part of the patient's medical record, whether that be on paper or ideally in the form of an electronic medical record. And finally, as I hope we've shown, that this can open the doors to treating a different, larger range of treatable tumours. Thank you.